Good morning, everybody. Welcome to the CMC Ludhiana Grand Rounds. Today we have Dr. Deepak Singh from the Chinchpada Christian Hospital to present the Grand Rounds. He would be talking about on the healthcare in India are not for-profit secondary hospital the answer. Before he starts his presentation, I would request Dr. Sangeeta Mohan, who happens to be Dr. Deepak's MBBS batchmate, and she's been closely associated with Deepak for over 25 years or so. So I request Dr. Sangeeta to please introduce Deepak, and then Deepak can start his presentation. Thank you.
Good morning, everyone, and good morning, Deepak. It's a great honor and privilege that Dr. Ashish and Dr. Jairaj have given me to introduce a dear friend and MBBS batchmate, Dr. Deepak Samson Singh, MBBS, MS General Surgery, MCH Pediatric Surgery. Deepak hails from Mussoorie in the Himalayas, and his family, he is born to Reverend Swami Sundar Singh and Mrs. Pramodini Singh, who instilled strong values of helping the community in Deepak, which we all batchmates have seen. His home in Mussoorie was a home away from home for us, and any excuse, most of the boys would run to Mussoorie to enjoy their hospitality. The community work is continued by Deepak's brother, Reverend Pradeep, and wife Vidino. Deepak and family have had long association with Christian Medical College, Ludhiana, Christian Dental College, Ludhiana, and the Emmanuel Hospital Association. In fact, his sister, Dr. Pradibha and Dr. Vikrant Milton, they are part of EHA now. They both did their dentistry training in Christian Dental College. Deepak did post-MBBS service agreement in two of the mission hospitals in EHA, under EHA, Makunda, Assam, and Chinchpada. When he came back for his PG studies in MS General Surgery, he was joined by his lovely, bright, and singing wife, Dr. Ashita Wagmare, alumnus of CMC Vellore, and she pursued her MD General Medicine here. Both of them, after their PG studies, went for their service agreement with the Emmanuel Hospital Association and started their work in an almost closing down hospital in Tejpur, Assam. From 2 patients per day, within a week, they started having 200 to 400 patients per day. It was no surprise to any of us. God has blessed him with Arnav and Tara, 2 beautiful children who are studying in Hebron, Ooty. Later, Deepak and Ashita, after the hospital was well established, went for their higher studies in CMC Vellore. Deepak did his MCH pediatric surgery there, and Ashita went on to do some fellowship in intensive training. Now they are back in Chinchpada Christian Hospital doing the Lord's work and working and helping the community, especially in the COVID time. And as of now, he's the regional director of the Northern region for the Emmanuel Hospital Association and the SAO of the Christian Hospital Chinchpada. So over to Deepak for the topic for today, healthcare in India. Are not-for-profit secondary hospitals the answer?
Thank you so much, Sangeeta, Dr. Sangeeta, for that elaborate introduction. And I'm grateful for this opportunity to be able to be part of this great program. Thank you so much for the time that you have given me at this time to share some of my thoughts and some of the things that I have learned over the years. Respected Director, Dr. Bhatti, Principal, Dr. Jairaj, Dr. Sangeeta, the Registrar, various my teachers, colleagues, and friends. It is my privilege to be presenting this morning before my teachers, colleagues, and friends. As we look at healthcare in India, the question I want to grapple with today is, are secondary hospitals, which are not for profit, the answer for the woes that are prevalent in healthcare in India? And as we grapple with these questions, I would like to tell you the story of a little boy called Anuj, who was 8 years old. And he came to us having had seizures and aspirated, very sick. He was diagnosed to have childhood tetanus. What a tragedy. It's no surprise that he lives in a jungle, has not been immunized. And he was branded, as you can see in the right lower picture, on both his hands and feet, and also on his abdomen and his chest for the seizures and the breathlessness that he was suffering from. He has spent the last 7 weeks in our hospital being treated for tetanus. He has come off his tracheostomy and he's eating well and is ready for discharge. But this is the reality that we face in India, especially in the rural areas. Or I could tell you the story of a man who was brought to us with an empyema that had been neglected. And when we put a chest tube, there were maggots crawling out of his chest tube for about 5 days. Or I could tell you the story of this neglected scalp wound of this little boy, which had maggots crawling out of it. Or of this man who has had branding of the neck for metastatic cancer of the throat. How is this possible in 21st century India? The Bohr Committee, way back in 1946, recognized the need for a 3-tiered system to take care of the healthcare needs of India. It envisioned a strong primary health setup. It also, which took care of the preventive and curative aspects of our healthcare, a secondary system, which was mostly curative, but treated most ailments, and a tertiary level, which would have advanced treatment and a referral system. The present status is quite challenging. And unfortunately in India, for a cold, now we demand to see an ENT surgeon. In a recent study by the Niti Aayog, India, the second most populated country on earth, has a very low hospital bed to population ratio. In places like Kerala and other states, it hovers around 1 or so per 1,000 population. But in other states, it is around 0.7 per 1,000 population. It is in rural areas, it is as low as 0.3 per 1,000 population. The pandemic has thrown up a lot of questions of the adequacy and distribution and the equity of these services. The affluent are able to afford access to healthcare at will. But strangely, the pandemic made it a level playing field with many people with resources not finding beds or oxygen. And above these, we have the challenges of corruption, the poor infrastructure, and the skewed health-seeking behavior in most areas of our country. Most hospital beds, as this slide shows, are concentrated in the urban areas. And 60% of our population lives in rural areas, but 80% of our beds are all in urban areas. The not-for-profit entities form a very small portion of the utilization of hospital services and the number of beds we have. We account for 2.4% of inpatient treatments and 1% of OPD treatments in the country. These, according to the Niti Aayog, have now been divided into 4 categories, which include faith-based hospitals, community-based hospitals, cooperative hospitals, private and private trust hospitals. According to the VK Paul, in his foreword, he writes that the not-for-profit hospital sector has a reputation of providing affordable and quality access of healthcare for many. This sector has done yeoman's service over the years with some institutions from before independence. Although various institutions have been established for various different purposes, this sector provides not only curative healthcare, but also preventive healthcare and links healthcare with social reform, community engagement, and education. They utilize the resources and grants provided to them by the government and provide cost-effective healthcare to the population without being overly concerned about profits. However, this sector remains largely understudied and with a lack of awareness about the services in the public domain. India has categorized our districts, which are most needy, as aspirational districts, which need concentrated effort for development and healthcare. These districts have poor socioeconomic indicators, and improvement in these districts can lead to an overall improvement in the human development in India. These are some statistics from our own district where we work in Nandurbar, which also is an aspirational district. And you can see that it has a high malnutrition status. There is very low human resource as far as healthcare is concerned, and a very high incidence of anemia. In a survey which I conducted for healthcare professionals, for a thesis I was writing about the problems and prospects in access to health, we found that of the 60 people who responded, almost half worked in semi-urban or rural areas. And most of them had a work experience of more than 10 years. Most worked in level 1, 2, or 3 hospitals, and a significant number were from a teaching hospital. But again, 60% disagreed and strongly disagreed that the government network was adequate to take care of all the healthcare needs of our country. And a majority felt that not-for-profit healthcare facilities are important in both rural and urban settings to take care of the healthcare needs of our country. A partnership between the government, private players, and not-for-profit entities is a better model for sustainable and equitable healthcare delivery. The Emmanuel Hospital Association has been working in rural and semi-urban areas, serving the country for just over 5 decades. We have 20 hospitals located in different parts of North India who work for the poor and the marginalized in rural communities. These are very close to or within the aspirational districts as described by the Niti Aayog of our country. We treat, and these are pre-COVID figures, close to 1 million patients in the OPD. 1 lakh people actually are provided inpatient services. We conduct about 33,000 surgeries, and about 25,000 women gain access to safe maternity care. A significant contribution was made by our hospitals and community projects during the COVID pandemic, both in the first and second wave. Relief work mainly in the first wave, and the hospitals then opened their doors to provide treatment in the second wave. The journey of the last 3 decades has brought us to Chinchpada Christian Hospital, where we have been working for the last 7 years. This hospital faced a possibility of closure, again, between 2008 onwards, with a lack of medical personnel. When we started off, we just had 20 staff, of which only 4 were nurses and the 2 of us were doctors. It was the most probably trying time for 2 specialists trying to run a hospital which was needed but had no resource or a backup plan. Today, we enjoy having a big team of close to 80 staff with 7 doctors, 25 nurses, and various other areas of staffing which are required. Taking baby steps, a rudimentary ICU, which was primarily nurse-based, was started with an AMBU bag for our first patient who needed ventilation. I still remember bagging the first patient for almost 3 days before he came around and was able to be extubated. The late Dr. George Annie Matthew, a classmate and a friend, was instrumental in us acquiring our first ventilator, which is seen here, and Ashita is working on it. Today, we have a 7-bed facility with piped oxygen and ventilators, and this is one of the most well-utilized facilities in the hospital. A good lab is something which assures quality of delivery of healthcare. We started off with a 1-room facility with a few test tubes and a 1-man army. The facility now has been upgraded to an entire floor with different rooms for different sections of the diagnostics being carried out. Our patient numbers have been steadily rising over the years. COVID has contributed to a small dip in patients accessing our services. Patients come from up to 5 hours away to access our services. We were the only non-government facility open during the entire lockdown period, and our inpatient services were well utilized. We grapple with diseases like tuberculosis, chronic liver disease, dengue, malaria, and sickle cell anemia. NCDs are also a big part of the work we do here. Over the last few years, we have been able to perform quite complicated surgeries like bladder augment with Mitrofanov, a lateral pancreatic vaginectomy, DP flaps for lip reconstruction, parotidectomies, laparoscopy, and endourology. A good outreach for palliative care, sickle cell disease, and disability rehabilitation has been developed over the last few years. These are the most marginalized among the marginalized in rural areas. We have treated close to 500 patients in our home-based palliative care program. The team visits these patients under their care and provides dressings, medication, and bereavement care to the families who are suffering in this way. Sickle cell disease is a very high prevalence, with close to 30% of the tribal population being carriers and 12% having the disease. Most of the people with this disease do not reach the age of 30 years. Just yesterday, a young girl of 22 passed away with severe chest syndrome. Some 200 children and adults follow up regularly for sickle cell disease treatment. All these people are provided medication at 50% of the cost. Our teams also help in getting the necessary certification for the benefits from the government, which these people are eligible for. We started off distributing assist devices to the specially abled among us. A year ago, we started a good OT department to back up our community-based rehab program. In our block of 120 villages, we have found more than 400 people who suffer from disability. And this excludes people with sickle cell disease, which has also been brought under the ambit of disability. One of the great blessings for us has been partnerships with various people, organizations, and the government. And the government has been able to provide us free tuberculosis kits for treatment of patients. We have treated close to 300 patients successfully, and a total of 93 patients are being followed up currently and receive free drugs and support. The hospital provides free rations to all the people who are on ATT. We also hope to start a free gene expert service for a quick turnaround of patient. This young migrant lady who helps her father cutting sugarcane in the fields as a laborer was brought to us with swelling of the left neck. We investigated, including an FNA sample of the lymph node, which was sent for the TrueNat, TB TrueNat. And within 2 hours, we had the report, were able to start her on treatment, and which was again free. This otherwise would have taken about a week if we had sent it to the government lab. Our partnerships with the local government help us acquire food grains, with which we are able to provide free food to all our inpatients and their relatives twice a day. In addition, all the patients get an egg and fruit every day. We have also been able to provide livelihood-saving measures for our palliative care and disability patients who have been affected severely by the pandemic. Many of the patients who come to us in our OPD after a gap of many months tell us that they have run out of money, and that's why they are coming late. And they are not able to afford many of the medicines which we provide, even at very low cost. Research is something we have really enjoyed doing with partnerships from our alma mater for surgical research, which includes the Falcon, Cheetah, Talon, and now the Penguin research. CMC Vellore for the NSS-CFI study. We are also doing research in pesticide poisoning. And the photo on your right is a research we are doing with an artificial intelligence-based radiology software, which helps us diagnose COVID and tuberculosis. This has a 76% positive predictability for COVID, and it was used extensively during the time that we were hit by the second wave. We have been able to publish a few papers, and we thank God for the partnerships we have with the University of Edinburgh and CMC Ludhiana and Vellore for many of the research that is going on. The JEET NGO gave us the award for being the best public-private partnership for the National Tuberculosis Control Program in the district. The highlight of the year is when students from CMCs, both CMC Vellore and CMC Ludhiana, visit us and also students from Believers Church Medical College come and get exposure to secondary hospital care. This is a time of much learning and fun with get-togethers and a little bit of leg pulling for students. I would like to welcome all of you to come visit us sometime as and when the pandemic permits or travel permits. In partnership with CMC Vellore, we also run a community lay leaders training program, which has been suspended due to the pandemic. We also do trainings for volunteers in palliative care across the villages in our locality. Our COVID response was much like other places where we had to start a flu clinic, literally under a tree, so that we could screen patients. This has since been converted to a nice shed where people can come and be in a shade. And the first wave helped us prepare for the coming days. And during this time, we were able to help migrant families which were returning from the cities with ration kits. And we were able to adopt about 500 families and help them for about 7 months, each month with a ration kit. Some of them really lived in squalid conditions in the fields during the period of the quarantine, as they were not allowed to enter the villages. We have been able to treat a significant number of patients with COVID and saw a massive influx during the second wave. We had to close down our non-COVID services for close to 3 months to service only COVID patients. We increased our bed capacity from 54 to 84, and we had to increase the piped oxygen to almost 46 beds. Close to 1,200 patients were treated in OPD, and 540 of these had tested positive over a period of 4 weeks. We treated another 200 who were negative, but were very high suspects for COVID with severe pneumonia and hypoxia. We had a total of 79 deaths. These are some of the images of the work that we went on. This was a team which was small, but was stretched to the limit. And I would like to recognize the efforts of the entire team, which worked like one and gave it their all. Several times we felt that we could not go on, but God enabled us to stretch ourselves and carry on. Many stories of people being helped in special ways, finding new life, finding hope and comfort, despite their severe illness, can be told, but we will reserve these for another time. The local government and an NGO recognized the efforts of the team during the time of crisis with the COVID Warrior Award. We today are equipped with monitoring and ventilatory equipment to manage up to 67 patients who need oxygen and up to 15 patients who can be ventilated or given ventilatory support at any one time. Oxygen was a big challenge for us as we had to fetch cylinders from 125 kilometers away. During the peak of the wave, the vehicle would have to go sometimes twice a day to Surat to get these cylinders. Often we would get news that oxygen was not available or would not be available to people from other districts. We today are blessed with a PSA plant donated by the Azim Premji Philanthropic Initiative. This is fully functional and has reduced our work of fetching cylinders from once a week to maybe once a month or once in 6 weeks. I would like to thank our friends, family, alma mater, like-minded institutions like CMAI, APPI, Tata Trusts, who have backed us up with prayers, donations, and with equipment. Occasionally, we find ourselves on the cover of highly regarded publications or a newspaper article. But it's not all work, folks. We do have our moments of fun. We have staff get-togethers, but not for the last year due to the pandemic. Small group dinners, outings to scenic spots, and of course, shopping in Surat, the diamond capital of the world. We're not able to shop for diamonds, but yes, we do go to Surat. Every year during Christmas, we get together as staff and families and hold a cantata to share the good news with the people we serve. The challenges for not-for-profit secondary hospitals remain. I still chuckle at the fact that once Dr. Dhruv called me and said, "Hey, your parcel has come back," because the courier said that place does not exist. Low income, low resource, lack of supplies, lack of people. lack of education or educational facilities for children, lack of entertainment, and the hard work that has to be put into these places are the challenges we face and continue to face every day. There is much that can be achieved by way of secondary care if we have God's presence with us, are committed to our work, and study and work hard. I think the key word is partnerships and networking. And we can have a good secondary setup, which has all the ingredients of good, ethical, professional, and quality medical services. Who holds the answers to our country's healthcare woes? The government network is overwhelmed, the private healthcare out of reach for a majority, and the not-for-profits too few and far between. The question I need to ask myself is, what is my role and duty to the citizens of this country as a healthcare professionals, especially to the ones who are rural and who are poor? We have the privilege of being trained in some of the best institutions under the best teachers. What is our response to the ever-increasing gaps in healthcare? In conclusion, I would like to submit that secondary hospitals and partnerships may hold the answer to many of the healthcare woes of our country. This partnership with the government, citizens, NGOs can achieve much in both preventive and curative health. Good leadership, a team to work with, and the presence of God are essential for our kind of work. A small intervention has great and far-reaching impact in areas which are underserved. I think the answer lies in increasing our presence to reach a bigger section of the population. Imagine if all 117 aspirational districts had a fully functional secondary healthcare facility in all their blocks. I would like to end with the story of Chalubai, who had severe COVID, was in the ward and developed a thrombus of her right hand. We were able to perform a embolectomy using a Fogarty catheter. And today, 3 months later, she is back with a fully functional right hand. It's about that one life saved, the one limb saved, the one child saved, which can alter our country's history. Thank you very much.
Thank you, Deepak, for that excellent presentation. And the way you people are changing the place. I remember working there, and you brought so many new things, the ventilators, the ICUs, and the change the community, and so much of work happening there. So you can unmute yourself and ask any questions if you have for Deepak, and he would be happy to answer. There are plenty of comments coming in the chat box, Deepak. So do you get newspapers the same day? Times of India, we used to get 2 days, old newspapers those days.
Yes, we do hardly get any newspapers at all. I mean, most of them are Marathi and the local this thing, but we don't really.
Yeah, we used to get it from Bombay those days. Yeah. So you have pediatric surgery services there, general medicine, and anesthetist.
Yes, so we have surgery, medicine, and anesthesia, but we do most things. Right now, our ward is full of pediatric patients, and also we have a lot of obstetric, not so much obstetric, but yes, gynae work, and we do a lot of, dabble in a lot of other things as well. Yeah.
So Deepak,
hey, Deepak.
one thing, hi, Dhruv is there, yeah.
Hi Deepak, great work. It's so lovely to hear from you and see all the work that you've been doing. For people who don't know, Deepak has been at this kind of work right from a long time ago in Tezpur. He started a defunct hospital in Tezpur on the other side of India, and now in Chinchpada. Deepak, thank you very much for all you do. And we hope that all of us can, in our little ways, keep supporting you.
Thank you so much, Dhruv. Thank you.
Ashish.
Yes, sir.
Deepak, thanks for joining us, and it's very encouraging to all of us the way you are working there. As Dhruv had mentioned just now, we are familiar with your work which you have done in Tejpur as from our pediatric surgery department. Dhruv was a regular visitor to your hospital, and he used to share with us what all improvement you have made. At the same time, it is extension of CMC Ludhiana vision and mission. You are providing holistic care to all those who come to your hospital. And I am very glad it's not only medical care you are providing, you are into research as well. Because many sponsored students, all those who have to work in rural mission hospital, they start thinking once we are there, we won't be able to, carry forward all these activities. But you have proved, even if we are in rural hospital and we are willing and determined, we can achieve all these targets in our life. And at the same time, you are into teaching as well. It's you are not keeping to yourself whatever you have learned throughout your different facing different challenges in Tejpur as well as in Chinchipada. You are sharing with others, as you were mentioning, other hospitals are visiting for the exposure. Another thing which I would like to highlight, being a regional director of EHA. So I am expecting in coming years, your presence will make difference in the leadership of EHA, and you will contribute further towards the growth of EHA. That is another job you have at hand. And I still remember I called you for the interaction with our sponsored candidates. And I'm sure in coming years, once COVID challenge, this crisis is over, you can visit and interact with our students just to encourage them, share with them, and listen to their queries and helping them out. And if possible, we'll send our students as well to your hospital. And me and Kavita, we would like to visit your hospital. And last time I was talking to Dr. Sampath Kal, he was visiting your hospital. He told me what all work you are doing. So all of us are very proud of you. God bless you.
Thank you, sir. Thank you so much.
Thank you. Any comments for Deepak? Anybody can unmute and talk to Deepak. So everybody, I think Deepak, are you able to see the comments? Plenty of appreciations in the chat box there.
Yes, thank you so much. Thank you. Thank you, everyone.
Yeah. Okay, Deepak, I think that's it from us here at CMC Ludhiana. Thank you for accepting our invitation and giving an excellent presentation. And we expect to meet sometimes in Ludhiana when you come here.
Thank you
Take
so
care.
much. Thank
Take
you.
care.
Thank you, Deepak. Thanks.
Thank you, sir.